today we're going to talk about sort of mostly going to focus on maxillary and orbital trauma that happens in kids. And you'll see really there's going to be a specific age group that we're going to focus on, because I think this age group is really the ones that are at the highest risk of having problems. And of course, as you know, the difference in children with trauma is the fact that they're still growing. And so we always worry that, you know, how their growth is going to be once their reconstruction has finished. And so follow-up is extremely important in all patients, but particularly in kids, and that's another focus. And so if we're going to talk about or worry about sort of how these kids are going to grow and how their faces are going to develop after not only the trauma, but potentially surgery that we give them, then we also need to know a little bit about how the face grows. And so I want to sort of spend some time talking about what's out there in the literature and what we know about facial growth, and then try to figure out, you know, taking this knowledge, how can we use this knowledge to better treat our patients? So what is clear in the literature is that facial growth is really genetically driven. The amount of epigenetic influence is pretty minimal, it appears. That genetics play a huge role. That's why you look like your parents and your kids are going to look like you. And so it's extremely important. So a lot of times that's out of our hands. So genetics guides how facial growth happens. Of course, as you know, there are no growth centers within the facial bones like epiphyseal plates that we see in long bones. And the bones of the face grow by deposition, resorption, and by suture separation. And really early on, the primary driver of facial growth is brain growth. So as that brain develops and as your brain expands, it actually pushes the face out and down. And it really determines how large your orbits are and how wide your face is. So that's something to keep in mind. Of course, epigenetics do have a role, but I would say that's probably less than 10 to 20% of facial growth. And this involves muscle action, primarily the bigger muscles in your face, like the muscles of mastication. Also sinus development, right? As your sinuses develop, your face expands. And then adult tooth eruption also has a role, because as your adult teeth start erupting, your maxilla and the mandible grow in vertical height. So when we look at the pediatric facial skeleton, it's different than the adult skeleton. The pediatric skeleton is primarily cranium. So there's a large cranium and a small facial volume. So it's an 8-to-1 ratio compared to 2-to-1 in adults. And the sinuses start developing. So we're born without sinuses, and then we start developing them. The maxillary sinus around 5 to 6 years of age, and the frontal sinuses again around 6 to 8. And then, as we said, sort of tooth eruption happening also around 6 to 8, which is guiding vertical growth of our mandible and maxilla. So just a picture, just to sort of clarify that, you can see the infant skull on the left side is mostly head and orbits, and the maxilla and the mandible are very small. So if this infant is involved in an accident, they're going to injure their cranium and maybe their orbits prior to anything else. Whereas in the adult, that's a different story. And so just the two skulls superimposed, as the brain expands forward and down, it pushes the face forward and down, and really has a big contribution in terms of facial development. And we can go back to looking at our head circumference charts. We often ignore these or only look at them when we're sort of focused on how the brain is developing. But this tells us a lot about how other portions of the face are growing. And so we look at that chart, and it's clear in that first sort of 6 months, the line is vertical. This suggests that growth is very rapid. So the brain is rapidly expanding. That means the cranial base is rapidly expanding, which means that the anterior cranial fossa is expanding, which comprises the roofs of the orbit. So our orbits are growing fairly rapidly in the first 6 months of life. And then even up to 1 to 2 years, there's fairly rapid growth. But after about 2 years and then 3 years, and a lot of charts were now changed from monthly to yearly because growth becomes slower and slower. And generally by 7 to 8 years of age, our cranium and our orbits are about 80 to 90% adult size. And so an injury at that stage is going to cause less a growth disturbance than an injury at 6 months of age before things have developed. So again, something to sort of keep in mind when we're approaching these kids that are injured. And the same thing with permanent tooth eruption, again, around the central incisors and the molars happen between 6 to 8 years of age, and that's when our maxilla and the mandible start growing vertically. That also coincides with expansion of our maxillary sinus, which also is contributing to vertical growth of the maxilla and projection. And so if it was ideal and these kids were not traumatized and we had an elective practice, we could choose when to operate on them. This would be ideal times in this sort of slide when we would operate. So the cranial vault is, again, 50 to 60% adult size by 1 year and almost 80% to 90% growth even after 2 to 3 years of age. So if we have to operate on the vault and can wait, that would be ideal. So in elective cases for craniosynostosis, generally 12 months of age is an appropriate time because our surgery is not going to affect growth very much. The orbits by age 6 to 8, when the brain essentially stops growing, are adult size. So doing significant orbital surgery around this time has little effect on overall development down the line of the orbits. The same holds true of the maxilla by age 8. And then the nose is probably the only outlier here where the septum continues to grow into sort of even adulthood. And so ideally, if we're going to do any final significant reconstruction of the nose, that can wait till the end of growth or end of teenage years. But otherwise, if we kind of keep this in mind, we get an idea of when the trauma happens, how big a deal is this going to be from a growth perspective, just from a trauma injury perspective. And then when we look at and review the trauma literature, it's clear that the earlier the injury happens and the higher the energy of the injury, the more growth disturbance that there's going to be. And this is potentially despite what our treatment's going to be. So if a kid gets injured at 2 years of age, that's going to be a significant problem than if they get injured at 8 or 9 years of age. And the other issue here, and this is what we're going to focus on for the rest of the talk, is that the upper face is pretty much static. There are really very few forces acting on the upper face other than sort of brain growing, potentially the septum pushing, and some of the muscles of mastication pushing on the upper face. That really is growing through separation of sutures. There's really no function or movement to the upper face. And so the upper face has a very low opportunity to remodel after an injury, compared to the mandible. The mandible, which is a stress-bearing bone that's constantly moving and has pretty large muscles acting on it, actually can remodel significantly better than the orbits and the maxilla. And so if we're not anatomically perfect on the mandible, there is a good chance that that mandible will continue to improve based on that soft tissue action and muscle action, whereas this is not true in the orbits in that maxilla. And that's very clear in the literature.